Thanks so much for the kind introduction and Dr. Sami for the invitation. So I'll talk about the next 20 minutes about ctDNA and our nurse Liza and pharmacist Nicole and APP Scott are in the audience. And for us, the president is talking about last week's results of liquid biopsies, and the future is discussing who in the next week will be getting liquid biopsies and what kind of how we influence the care of patients daily in clinic. These are my disclosures. Some of them are relevant to the talk today, and also we will be talking about off-label use of some of the liquid biopsies. And there will be implications regarding diversity and making sure that we have an appropriate impact across the board. A quick plug, there is a review article that we had a chance to publish. It's published in JCO. A lot of the talk and implications that we talk about today are summarized in this review if you get a chance, and we can share the slides as well at the end of the talk. This is not my words. ASCO a few years ago had a whole session for ctDNA, and it called it the dawn of new era. And the term ctDNA probably is not holistic because it doesn't include all the things that liquid biopsies encompasses. So the term liquid biopsy probably is more appropriate because it's not about circulating tumor DNA, it's also about circulating tumor cells. And as one of my colleagues put it, there's a lot of tumor trash that's coming out from the tumor, not just cells and DNA. You heard yesterday about fragmentomics, vesicles, RNA. So the field of liquid biopsy and the term liquid biopsies is getting beyond just circulating tumor DNA. It's also having an impact not just at the metastatic disease level, it's having an impact at the treatment response. This whole field of term that we borrowed from our hematology colleagues called the MRD, or minimal residual disease, or molecular residual disease, but also, as you heard yesterday, several multi-cancer early detection assays as well as colon cancer specific assays. We'll talk about some of them in the future directions that are having an impact at the diagnosis level as well, so not at the patient level, but also at the population level. It also has introduced a new term. Dr. Khan and I were just talking a few minutes before the talk about this new setting that this field of liquid biopsy has introduced. I call it the adjuvant plus. So it's the time between the finishing of curative intent therapy to the time where radiographic occurrence, you have molecular recurrence, not radiographic occurrence, and there's an opportunity to intervene, because sometimes that could be 9 to 12 months, depending on which study you look at. And it's not a future goal. Dr. Anderson talked about pancreas cancer yesterday. We just completed a randomized phase 2 registrational study using a KRAS vaccine for patients with pancreas cancer that were MRD positive post-curative intent surgery, but didn't still have radiographic recurrence. So there's an opportunity to intervene before the first line therapy, so line -1 therapy. Briefly about the settings, platforms, biology, because you'll hear a lot of liquid biopsies, so it's important to know what platform are you talking about, which assay, which setting, which disease type. Broadly speaking, based on the method, they can be classified into tumor-informed platforms, meaning that you need a piece of tumor to personalize whatever assay you're making, versus plasma-only platforms that are using different signals based on cancer, or DNA, or RNA, or methylome. So those are tumor-informed or plasma-only platforms, and they all have their pros and cons and implications. Again, this brief cartoon kind of simplifies the methodology based on which you can classify liquid biopsies. Briefly in the clinic, a lot of us know we're seeing a lot of young patients with colon cancer and rectal cancer, and a lot of them are left-sided colon cancer, even though colon cancer is one long piece of tubing. 90% of young onset colon cancers are left-sided or rectal. There's a lot of interesting research going on as to why that's happening. Is it the diet? Is it the microbiome? And also with increasing lines of therapy, this is a slide that now every other talk I have to update because there are more options. Just a couple of months ago, a new drug for KRAS G12C, 2% of colorectal cancer got approved. So it means that these patients will be getting years of treatment. On average, the median survival in some of the new randomized trials is upwards of 50 months, 60 months. So to rely on a colonoscopy biopsy from 5 years ago about a patient treatment plan today after so many lines of therapy, you don't have to be an oncologist to realize that that biopsy is probably not relevant to today's treatment decision. Based on that, let's see how we're using this in the clinic. So first of all, for a patient with colorectal cancer, the most common GI malignancy, in the first-line metastatic setting, it's important to realize that opportunities for precision medicine can be missed a third of the time. It was gone are the days where you can just get away with giving everybody FOLFOX with bevacizumab, because if you look at these multiple trials, including a randomized trial, the average survival is almost a year difference. So it's important to know your mutational status, at least the basic KRAS or BRAF mutation, so you can probably, in my opinion, give them anti-GFR because, if you look at, regardless of the study you look at, it's almost a year of survival based on the biologic agent you use. But why is this not happening? So this is again work from our Japanese colleagues where they looked at, in a systematic fashion, in a well-run hospital setting, the turnaround time for liquid biopsy was less than 2 weeks, and now it's allowed down to less than 7 days. But for tissue, it still takes 4 weeks. Sometimes it's the availability of tissue in-house or tissue elsewhere. And again, nothing against the pathologists in the audience. Dr. Yo is on the panel here. Every pathologist, regardless of whether it's City of Hope, Harvard, or MD Anderson, they'll tell you, they'll give you the results back within 2 weeks, if not sooner. But this is the reality. This is a study from across the nation. 81% of the time, basic RAS testing was never back within 2 weeks. So that is one of the key barriers that liquid biopsy can overcome, because you'll have your RAS status back within a week or 10 days. And sometimes, we have patients where the tissue testing is never available because the initial biopsy wasn't sufficient. It's not uncommon to have just enough to call it a diagnosis, but not enough to call it for mutational testing. And again, as we talk about anti-GFR, there's this new 3 trials now published showing that resensitization or rechallenge is an option, and you can spare the toxicity to the patient who already has, for example, the cartoon at the bottom that shows that those have resistance mutations, so they won't benefit from anti-GFR, they only get the rash. And this is, again, the turnaround time to re-emphasize is key, that again, liquid is not meant to replace tissue, but can be complementary for not just colorectal cancer, but an array of other cancers too within GI malignancies, where this list of tissue-specific approvals is increasing. But also on the right-hand side, you have agnostic approvals. So MSI, you heard Dr. Gruber in the talk earlier today, as we'll talk about MSI as an agnostic marker. You have these fusion drugs, Retis addition, TMB, and again, you have to be careful because liquid results and tissue results may not be completely harmonized. And also, the same liquid biopsy might have different implications for the tissue type you're dealing with. But regardless, again, this is meant to be complementary, not to replace it. And we published on some of the work on validating MSI. Again, if there's one biomarker that you cannot miss is microsatellite instability, not just for colorectal cancer, but for even pancreatic cancer and across tumor types. This is the first indication for which we had an agnostic approval, because this is the first time I started hearing the word cure in stage 4 setting. So you cannot miss these opportunities. HER2, we were just commenting with a colleague earlier today about 4% of colorectal cancers can have HER2 positivity, and a lot of these combinations are very familiar to our breast oncology colleagues, but now most of them are also approved across GI malignancies. And liquid biopsy also is not just about mutations or DNA. You can detect amplifications, you can detect other aberrations for which you can act upon. And again, this is from one of the Heracles study that led to the approval of the patented trastuzumab. Liquid biopsy identified ERBB2 amplification or HER2 amplification in 98% sensitivity. And why it's important is because this is a patient who was told to consider hospice within 2 cycles of trastuzumab pertuzumab with ERBB2 amplification picked up on a liquid biopsy. You can see the impact it's having. Switching gears to a poster child of ignored poster child, I would say, of a very targeted disease is cholangiocarcinoma, which is essentially the cancer of the plumbing of the liver. And even though extrahepatic, intrahepatic, and gallbladder cancers are often just lumped based on anatomy and how surgery is done, if you kind of roll the dice, you will find something actionable at least a third of the time, if not 50% of the time. And some of these are very diagnostic too. Often, one of the other common cancers we see in clinic is CUPS, or cancer of unknown primary. They present with a large liver mass, but you don't know where the cancer started. Pathology can only give you so much information about, possible upper GI primary, cannot rule out lung, maybe it's something else. If you have an FGFR2 fusion and a big liver mass, that's intrahepatic cholangio, as proven otherwise. So it's not just actionable from a treatment standpoint, but also actionable from a diagnostic standpoint too. Again, liquid is meant to be complementary and not replace it. In one of our studies, we actually found more fusions on liquid biopsies than tissue biopsies. Again, if you compare head to head, tissue is the gold standard for any fusion detection. There are limitations on fusion detection on liquid, but why is liquid picking up more fusions in real world than tissue is because more often liquid will be completed. A third of the time, if not 40% of the time, cholangiocarcinoma diagnosis is based on ERCP. You saw multiple cases yesterday, the case by the fellow where there were 3 attempts at biopsy that was not even successful to diagnose adenocarcinoma, let alone genomic testing. Whereas unless you messed up the tube or didn't collect the blood or the tube got broken, the amount of shedding that's present in a cholangiocarcinoma patient is enough for picking up some of the fusions. And it's important to realize the same assays from the same companies have also evolved over the years. So a paper 4 years ago saying fusion detection was very low, the same company, same assay is now several folds better. So important to kind of keep that in mind. And again, not just for diagnosis, but at the time of acquisition of resistance, there are several FGFR fusion inhibitors approved now for cholangiocarcinoma. And when they acquire resistance, they develop mutations to the fusions that are bypass mechanisms. And again, they fleet over time. Just like the EGFR rechallenge story, there's also FGFR rechallenge as well, which you can pick up on liquid. In this autopsy study from the group at Brigham, every single piece of tumor shown here on the CT scan had a different mutation, whereas in blood you can detect it in a polyclonal fashion. Switching gears to a different application of ctDNA, it's about ctDNA kinetics. The half-life of ctDNA is only a few hours, which means that if you have effective therapy, within a couple of weeks, you should see things disappear. Again, in the case of immunotherapy with MSI, we underestimate how quickly immunotherapy can work. This is within 1 dose, 2 weeks later of a ctDNA assay showing the hypermutated MSI high gastric cancer disappearing within weeks of therapy. So we can see more than 90% fall within 2 weeks of starting an effective therapy. So it's not just the ctDNA, again, the term liquid biopsy is important because you can also see the plasma MSI status disappear on these patients who are MSI high specifically. And again, regardless of which company, which assay, this is a pan-tumor study, ctDNA clearance is the best prognostic and predictive marker. These patients are alive years out even if they have stage 4 disease. This is a paper using a plasma-only assay. This is a paper using a tumor-informed assay. Again, your ctDNA clearance patients very early on can be very different than your patient who's not clearing. So kinetics of liquid biopsy is another implication of having that baseline will allow you to do a kinetic because you can then see how much fold of whatever variant relief fraction or molecules per mil or parts per million of whatever assay you're using can change over time. Then the big this field of MRD. Important to realize why is MRD not possible for all tumor types. You heard Dr. Thomasetti talk about shedding. Why colorectal cancer has a lot of interest, regardless of which company or which assay you look at, colorectal cancer and GI cancers tend to be high shedders. So whatever assay you have will perform better in a GI malignancy as opposed to, for example, a patient with brain tumor. And again, that's true for a lot of other studies. But within colorectal cancer too, it's surprising, again, the same right-left story. Even the right-sided cancers versus left-sided cancers versus transverse colon that sometimes is neither left or right sheds different amount of circulating tumor DNA. And depending on where the metastases are present, a peritoneal only versus lung only versus liver only metastases can shed up to 20, 40, 60% different amount of ctDNA. So it's important to kind of keep in mind not to interpret liquid biopsies without clinical context. You heard about the tiger and the dog story. If the context, you have an enlarging lung mass, it doesn't matter if the liquid biopsy is negative, that's a low shedding zone. So you should rely your clinical judgment. So again, ctDNA is meant to be complementary to your clinical decision making, to tissue decision making, and you have to keep in mind these sanctuary sites that don't shed as much ctDNA as the rest of the body. Also, from a surgical standpoint, we have many surgeons in the audience, the surgical trauma induces cell-free DNA. So when are we assessing MRD? We're assessing MRD immediate post-op. Well, that's a bad time to be assessing any assay because you have a lot of background noise. So simplistically, we're looking for a needle in the haystack, and there's a bigger haystack. So how can we overcome this problem? You want to assess another time point beyond. So important is not the interpretation of a positive liquid biopsy in this day and age. It's more so making sure from a clinical context, you don't interpret a false negative as a negative. And how these results corroborate clinical findings, again, regardless of assay, regardless of company, regardless of study, your ctDNA positive patients, if you don't do anything about it, pretty much every single curve touches the x-axis, meaning these patients recur. And that's where the field of liquid biopsies right now, the ctDNA negative patients, you got to be careful because depending on the assay, depending on the study, depending on the year, it's never 100%. So you have 70, 80% cancer-free survival, and again, it's improving over time with repeated assays, and again, better assays as the same, even from the same companies. But it's important to know, like for a patient today in clinic, if I see them today, compared to a 92% chance of being cancer-free if their liquid biopsy is negative, they only have a less than a third of chance of being cancer-free at 2 years if they're MRD positive. And again, it's not just the implications of the assay. You have to keep in mind about patient well-being, how are patients interpreting the assay. We looked at quality of life, the metrics in a study that we presented at ASCO last year. And again, nobody wants to know about the positive assay, but you'd be surprised to know that patients still perceive those results as helpful. They would rather have this information. And again, it's an informed decision making. You want to have that conversation with your patients before the assay is done as to what am I going to do with the assay if it comes back positive, and what's the plan if the assay is negative, so expectations are clearly met. You heard about the dynamic study yesterday. I just wanted to emphasize we have a randomized trial showing that utility of MRD in a stage 2 setting not only led to the similar outcomes. So these patients the assay was done in Hopkins, the study was done in Australia, they made it happen, so it's possible, and they achieved similar outcomes whether you use ctDNA to guide chemotherapy or whether you use physician judgment. But I think more important than the result of this was the fact that one is only half as many people needed chemotherapy. You spared the toxicity to the patients who didn't need it. But also remember the ctDNA positive curves that I showed you. It's not a static death sentence. If you do something about it, compared to the studies on the left-hand side where the curves touch the x-axis. In the dynamic study, the disease-free survival of positive ctDNA was still 86%. Again, we need better regimens, but chemotherapy can convert these patients, and that's what we do. It's kind of like a real-time indicator of what mop-up chemo is about. Mop-up chemo is hopefully eradicating the microscopic disease that you can see here. So again, there are different units, different measurements, and with better assays, we can further increase. This is an update from the same study. With the better assay, they found these false negative cases as well. So important to kind of keep in mind that these assays are changing over time. And also within mutational status too, these assays have different performance. And again, there are 16 iterations, for example, of what a stage 3 cancer can look like. So somebody who's T1N1, who has a 92% chance of being cancer-free, a T4N2B, I don't care if their liquid biopsy is negative. That person, only has a third of a chance of being cancer-free, so they need chemotherapy. So you have to keep in mind that, you don't interpret liquid biopsies without context. In the future directions, I want to emphasize two things. One is liquid biopsies moving up the ladder to diagnosis. So there are colon cancer specific assays, and you heard yesterday there are multi-tumor or multi-cancer early detection assays. Again, that assay may not perform well for thyroid or prostate cancer, but see cholangiocarcinoma, colon cancer, pancreatic cancer, the unknown primary, the sensitivity of some of these assays is very intriguing. And again, it's not just about DNA, there's also circulating tumor cells. Cancer cells are heavier and less compressible. So this is one of the assays that we've been working in our lab with. The cancer, as the bloodstream is moving through this capillary system, the red blood cells, the white blood cells, they go through the narrow capillaries as well, but the cancer cells, because they are heavier, less compressible, they can get stuck within this 30-minute process without any staining, without any chemicals being used. And you can see the captured cells. These are on a mounted slide. You can then, just like pathology, use any kind of assay that has immunohistochemistry based, utilized on the membrane structure that DNA right now cannot provide. This is an example of a patient with colorectal cancer. Not only can you see circulating tumor cells that are cytokeratin positive, EpCAM positive, CD45 negative, but you can use it for development of other assays, including PD-L1, HER2, things that are not yet possible, including SSTR that we also develop for patients with neuroendocrine tumors. With that, I will stop and then we'll look forward to the panel discussion. Thank you so much again.